So, welcome to yet another session of anatomy lectures by the MEDI EXPRESS team. So, today we are going to deal with most of the other topics which are left in anatomy. So, starting with the pectoral girdle and the upper limb topics. The first one in the pectoral girdle and the upper limb, we have muscles of the hand. This is very important, and at least one question usually comes from this session. Okay, so muscles of the hand. The total number of muscles of the hand, they are 20 in number. When we count the muscles in the hand, you can look into your hand and then you can see the movements and all that. So a total number of muscles in the hand is 20. Now we have divided the number of muscles or the type of muscles in the hand as thenar muscles, hypothenar muscles, we have lumbricals, palmar introssi, as well as dorsal introssi. So now, first one we'll deal is with the abductor pollicis brevis. So, thenar muscles I'm talking about. The first one is abductor pollicis brevis. If you see the muscle over here, in your lateral side, we have the first one is abductor pollicis brevis. This one. Second one we have is flexor pollicis brevis. And we have a opponens pollicis over here. So these three muscles remember. Okay. In the same way, if you are just checking out the hypothenar muscles, we have abductor digiti minimi, we have flexor digiti minimi, and we have opponens digiti minimi. All the three, they are the same. Just in thenar muscle, we have pollicis brevis, and in hypothenar muscles, it is digiti minimi. Okay. Now, the only different muscle which is there in the thenar muscles or which comes under the thenar muscle is the adductor pollicis. This one, adductor pollicis. Okay, now you can see over here there is a muscle that is the adductor pollicis longus actually. So adductor pollicis over here that goes over here. This is the one. Next one is hypothenar muscle. In the hypothenar muscle, the separate one which we have is the palmar brevis. You can see this particular muscle is the palmar brevis. Now, as the name goes, abductor pollicis brevis helps for the abduction of the thumb. Flexor pollicis brevis helps for the flexion. Then opponens pollicis helps for the counting, and adductor helps for adduction. In the same way, abductor digiti minimi, flexor digiti minimi, and opponens digiti minimi, they again help for the same things. Finally, we had four thenar muscles. I'll write over here. Four thenar muscles. We have four hypothenar muscles. We have four lumbricals. We have four palmar introssi, as well as we have four dorsal introssi. So this is the total number of muscles in the hand. Next one, you need to know from where all these are originated. So remember, lumbricals. Lumbricals are originated from the flexor digitorum profundus. Lumbricals are originated from the flexor digitorum profundus. And what is the dominant nerve in the hand? Remember, the dominant nerve in the hand is the ulnar nerve, which is responsible for fine movements. And that is why ulnar nerve is known as the musician's nerve, or otherwise it is known as a laborer's nerve. Laborer's nerve or musician's nerve, because it is responsible for fine movements. Now, the nerve supply of the muscles of the hand is yet another important topic. Remember, there are two nerves that supply the muscles of the hand. They are ulnar nerve, and the other one is the median nerve. Very important. When the ulnar nerve supplies the hypothenar, third and the fourth lumbricals, four interossi, as well as the adductor pollicis. Remember, this is the nerve supply. The ulnar nerve supplies hypothenar muscles, the third and the fourth lumbricals, four interossi, as well as adductor pollicis. You can see adductor pollicis is one of the thenar muscles. So remember all the hypothenar muscles, then adductor pollicis, the interossei muscles, sorry, yeah, the four interossei muscles, and the third and the fourth lumbricals are by ulnar nerve. But whereas median nerve supplies the thenar muscle except for the adductor pollicis and the first and the second lumbrical muscles. This much you have to remember about the nerve supply. So I repeat once again, ulnar nerve and median nerve. Ulnar nerve will supply the hypothenar muscles, third and the fourth lumbricals, four interossei, as well as the adductor pollicis. Median nerve will supply the thenar muscles, first and second lumbricals. Now, after action of the interossei is very important. Now, for palmar interossei muscle, remember, it helps in adduction of the fingers, that is bringing the fingers closer. Okay, if you try bringing the fingers closer, that means your palmar interossei is working. Now, if at all you have to, separate the fingers, that is abduction of the fingers, remember the muscle which is acting is the dorsal interossei muscle. Dorsal interossei muscle helps in the abduction of the fingers, whereas palmar interossei helps in the adduction of the fingers. Now, we have already said lumbricals are originated from the flexor rigidorum profundus, but what is the action of these lumbricals? Remember, they help in the flexion at the metacarpophalangeal joint and extension of the interphalangeal joint. Remember, flexion at the metacarpophalangeal joint and extension of the interphalangeal joint. This is the action of the lumbricals. So that was a little information. Now coming to the clinical aspect of the nerves as well as the muscles of the forearm, muscles of the hand. Now, remember that if at all there is an injury to the ulnar nerve, injury to the ulnar nerve, that means there will be a partial claw hand. Partial claw hand. Okay, remember this. Now, also remember why there is a partial claw hand. That is because the nerve supplies, that is the hypothenar muscles, third and the fourth lumbrical, four interossei, adductor pollicis, they will not be doing its work. And that is why there will be a partial claw hand. But if at all injury happens to both ulnar and the median nerve, we have a complete claw hand. So complete claw hand it will be there. Now talking about the injury to the radial nerve. Radial nerve, if there is an injury, remember there can be a wrist drop, and even Saturday night palsy or a crutch palsy. Saturday night palsy is otherwise termed as a crutch palsy. Now, what happens here? The radial nerve will be compressed in the groove of the humerus in case of a Saturday night palsy. Now, in Saturday night, people go for partying and then they get, they get drunk and they sometimes the way the position of the person who is sitting in the chair, sometimes what happens, the entire radial nerve gets compressed between that of the the handle of the chair and that of the humerus. So what will happen at that point of time? There will be a wrist drop as well as Saturday night palsy and crutch palsy or crutch palsy. The next one is pointing index. Pointing index, what happens here is when there is an injury to the median nerve alone. Median nerve alone. How do we point a finger? Now we know median nerve supplies the thenar muscles, right? So at that point of time, the other two fingers, that is the thumb and the first finger, they will not be having, the second one will not be having a problem. Index finger will not have a problem, but what will happen to the other one? There will be like a flexed kind. That's why we have a pointing index finger. Next one is a ape thumb deformity. Ape thumb deformity is when the thumb is in the same plane as that of the palm, and that is occurring due to a median nerve injury. So there are two things, that is a pointing index deformity as well as the ape thumb deformity. The next one is carpal tunnel syndrome, also is caused due to median nerve. So these are a little of the clinical aspect regarding the nerves of the upper limb. Now remember, uh, extensor muscles of the forearm helps in extending the wrist. Extensor muscles of the forearm helps in extending the wrist. This is regarding the muscles of the relation of the muscles of the forearm with that of the wrist. So this much you have to remember. The next one is the sensory supply of the hand. If you just check these two pictures over here, this is the palmar surface, this is the dorsal surface. Now remember, the medial one and a half is supplied by the ulnar nerve. So the one in the green over here, that is one and a half, is supplied by the ulnar nerve, whereas the lateral three is supplied by the median nerve. You have to remember this. Lateral three, lateral three and a half actually, one, two, three and a half is supplied by the median nerve. Now, but when you come to the dorsal surface, remember the medial one and a half is supplied by, again, median one and a half supplied by the ulnar nerve, lateral, that is only to the distal phalanges, median nerve, and the rest is supplied by the radial nerve. So there is a difference. In the palmar aspect, only the ulnar nerve and the median nerve is working or is being supplying the hand, but whereas in the dorsal surface, we have medial one and a half by ulnar nerve, but other one we divide it to the lateral three by three and a half we divide it. That is, the distal phalanges has been supplied by distal phalanges is supplied by the median nerve, whereas the rest of the part is supplied by the radial nerve. So this much you have to remember. So the next one is the rotator cuff or the musculotendinous cuff. Now, for this, you need to remember four muscles. One is the supraspinatus muscle, one is the one infraspinatus muscle, and teres minor. Remember, all these are inserted into the greater tubercle of humerus. It is inserted into the greater tubercle of the humerus. But one more muscle is subscapularis. It is inserted to the lesser tubercle. It is inserted to the lesser tubercle. You can see over here. All these three are uh, inserted into the greater tubercle, but we have a lesser tubercle over here in which the subscapularis muscle is being inserted. Now, these are the muscles which are included in the rotator cuff or the musculotendinous cuff. Very important. You just need to know the muscles name. We will be dealing about the muscles in detail in the later hour. Next one. Next one is something regarding the flexor retinaculum. Flexor retinaculum. So talking about the flexor retinaculum, you need to remember that it is a thick connective tissue. I'll write over here. Flexor retinaculum is basically a thick connective tissue. Very important to know. Okay, and this forms the roof of carpal tunnel. This is very important. It forms the roof of carpal tunnel. Okay, now this particular flexor retinaculum, it turns the carpal arch into carpal tunnel. But how? That is very important. By bridging the space between the medial and the lateral parts of the arch. This is important to know. Now, some things which are important to know about flexor retinaculum are the contents of flexor retinaculum. The contents, there are totally 9 tendons. Remember, there are totally 9 tendons. And it is surrounded by a synovial sheath and as well as a median nerve. Now, let's see for the superficial one. Superficial, the flexor retinaculum, superficial to flexor retinaculum, we have few things, and that is ulnar nerve, then we have ulnar artery, and we have a palmaris longus tendon. These are the contents. ulnar nerve, ulnar artery, and palmaris longus tendon. Now, deep to the flexor retinaculum, that is through the carpal tunnel, what are the contents? That is median nerve. We have flexor digitorum superficialis tendon, that to 4 in number. Then we have flexor pollicis longus tendon, and we have flexor digitorum profundus tendons, that to 4. That's why 4, 4, 8, 9. That is what we have. Remember this. So 8 tendons, we have it through the carpal tunnel. This is what you have to remember. Superficial to flexor retinaculum, what and all we have. We have an ulnar nerve, we have an ulnar artery, as well as palmaris longus tendon. But deep to the flexor retinaculum, that is through the carpal tunnel, we have a median nerve, we have flexor digitorum superficialis tendon, then we have flexor pollicis longus tendon, as well as we have flexor digitorum profundus tendon. So this is what you need to remember in flexor retinaculum. I hope this is clear. Remember that flexor retinaculum is nothing but a thick connective tissue which forms the roof of the carpal tunnel. This is very important for you to know. Next one, coming to the cubital fossa. Now, talking about cubital fossa, the another name for cubital fossa is antecubital fossa. Remember, the other name for cubital fossa is antecubital fossa. I'll write over here antecubital fossa. Now we know that it is triangular in shape. It is triangular in shape and it is present in the anterior aspect. Remember, anterior aspect of the elbow. Very important information. Okay. Now, here we are going to deal with a little of the borders as well as the contents. So first one, it consists of 3 borders, a roof and a floor. Remember that. So lateral border, we have a lateral border that is by a brachioradialis. This muscle which you are seeing is a brachioradialis muscle. So laterally, so this is a triangle. We'll see what and all makes a triangle. So first one, we have a border. There is a lateral border that is by the medial border of the brachioradialis. The other one is a medial one. Medial border is by the lateral border of pronator teres muscle. So one side we have a brachioradialis, other side we have a pronator teres. Now, here, this part and this particular part, basically, we have 2 epicondyles. Now, the superior border, if at all we draw a line, a straight line between the both epicondyles of humerus, we will get the superior border. So 3 borders, one by the brachioradialis, other one by the pronator teres, and lastly we have a horizontal line, a superior border that is a horizontal line between the both of the epicondyles. Now, talking about the roof, or what are the things upon that? We have a bicipital aponeurosis, we have a fascia, we have subcutaneous fat, and definitely lastly we have a skin. So that is of the roof. And what makes the floor? You can see over here. Biceps, brachialis muscle proximally, as well as supinator muscle distally. This is the floor of cubital fossa. What you have to remember. So the floor is by brachialis and supinator, roof, bicipital aponeurosis, fascia, as well as subcutaneous fat and skin. So these are the things that consist of the, that becomes the border of cubital fossa. Now, next, let us see what will happen to the contents, or what are the contents of cubital fossa. Okay, so the first content which we are talking over here is right here, that is the radial nerve. Radial nerve is the first content of cubital fossa. Now, remember that this radial nerve travels along the lateral border. Remember this one, radial nerve. It travels along the lateral border of cubital fossa and then it divides into superficial and deep branches. It divides into superficial. You can see the superficial and one more branch is going inside here. That is a deep branch. Remember, radial nerve has motor, and sensory function. But where? To the posterior forearm. Remember, posterior forearm and hand. That is about the radial nerve, the content of cubital fossa, first one. Second one, we have a biceps tendon. Remember, we have a biceps tendon. Now remember, the biceps tendon passes centrally through the cubital fossa and attaches to the radial tuberosity. It attaches where? It attaches to the radial tuberosity. This is important to know. Okay, now this gives rise to the biceps tendon, gives rise to the bicipital aponeurosis. Bicipital aponeurosis. Now, and what does the bicipital aponeurosis do? They form the roof of cubital fossa. Roof of cubital fossa. The next one in the row is brachial artery. You can see brachial artery is also there, right? Before it divides into ulnar and the median, even brachial artery is also there. Now, remember, brachial artery bifurcates into radial artery and ulnar artery at the apex of the cubital fossa. Remember that when I write over here, it divides in the apex of cubital fossa. Important to know. Okay, and that is why the brachial pulse can be felt in the cubital fossa by just palpating medial to the biceps tendon. Okay, medial to the biceps tendon, if we are trying to palpate, we will feel the brachial artery pulsations. Next one is the median nerve. Sorry, next is the median nerve. Remember, median nerve travels medially through the cubital fossa and it exits by passing between the two heads of pronator series. We have a pronator teres over here. Between the two heads of pronator teres, this median nerve exits. Okay, we have a median nerve between the two head, it exits. Now, I'll write over here motor, it has a motor as well as sensory function. But where? It is the anterior forearm and hand. When radial nerve is having a motor and sensory function to the posterior forearm and hand, median nerve has its motor and sensory function to the anterior part of the forearm and the hand. This is important. Now, some other, the roof of the cubital fossa. I'll just draw over here. The roof of the cubital fossa also contains few superficial veins. Some superficial veins are also there. Now, which are the superficial veins? I'll just write. We have a median. Oh, sorry. Median cubital vein. And what does this median cubital vein do? They connect the basilic and the cephalic veins. So this is important to know. Which is the superficial vein which is present in the roof of the cubital fossa? That is median cubital vein. So this is important. Now a little of the clinical relevance. Now if at all there is a supracondylar fracture, remember supracondylic fracture basically is a fracture of the distal humerus. If at all that is there, there can be weakness of the flexor pollicis longus. Now, in this type of injury, what happens is the contents of the cubital fossa can be damaged. Now, I'll tell you in detail. So, we're talking here about supracondylar fracture. Okay. Now, here it is a transverse fracture actually. Transverse fracture, or even it can be an oblique fracture. Now, if at all a person falls on an outstretched hand, there can be a supracondylar fracture. And it is more common in children. Remember, it is more common in children. Now, in this particular kind, what happens? We have a cubital fossa over here. We have a lot of contents. Those can get damaged either because of direct trauma, or it can be because of a swelling following the trauma. Okay. Now, if there is a brachial artery damage, brachial artery, very important one, please write it down. Brachial artery damage, it can cause Volkmann's ischemic contracture. Volkmann's ischemic contracture. That is uncontrolled flexion of the hand will occur. Now, if at all there is a damage to the anterior interosseous nerve, that is anterior interosseous nerve is a branch of median nerve, remember, branch of median nerve. Okay, and along with that, if there is a damage to the ulnar as well as the radial nerve, then there can be a weakness to the flexa, sorry, flexa pollicis longus. So this is the one which you need to know regarding the cubital fossa. Okay, so next one we are going to deal with is the anatomical snuff box. Now, talking about the anatomical snuff box, what you need to remember is the content of anatomical snuff box. So what is the content of anatomical snuff box? And that is radial artery. You can see over here, right? Radial artery over here. The one which I'm going to mark it in white. Yes, this is the radial artery. Okay, now laterally what are present? We have a extensor pollicis brevis tendon. We have an adductor pollicis longus tendon. So what and all we have? We have an extensor pollicis brevis tendon, as well as we have a abductor pollicis longus tendon. Okay, you can see in the picture itself. Extensor pollicis longus tendon and abductor pollicis. So this is present laterally, these both. Now, what is present medially? We have a extensor pollicis tendon. An extensor pollicis longus tendon actually. Extensor pollicis longus tendon. Okay. Now, so this becomes radial artery over here. So this is the anatomical snuff box. Now, with regards to this, there is a little information which I want to share of radial artery, and that is not radial artery, anatomical snuff box. That is, what is the other name for anatomical snuff box? It is known as radial fossa. So another name for anatomical snuff box is radial fossa. And what it is basically, it is a triangular depression found on the lateral aspect of the dorsum of the hand. Remember, triangular depression at the lateral aspect of the dorsum of the hand. So if someone is asking, what are the bones which are present, or which are the bones which are present in the anatomical snuff box, you should remember as the proximal border. As the proximal border, we have styloid process of the radius. Styloid process of the radius. And as the floor of anatomical snuff box, we have carpal bones, we have scaphoid bones, scaphoid, as well as we have trapezium. So these are the bones which you need to remember in relation with that of that of anatomical stuff box. So this was regarding anatomical stuff box. This has been asked again and again in the examinations.